Hello, everyone. Good Friday to you today, and welcome to SADS Live 165. It's great to get to be with you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, and the Winland Smith Rice Sudden Death Genomics Laboratory. But I come here on behalf of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, where I've served as president of the board for almost 20 years, since 2006. So I give you greetings from our former CEO, Alice Laura, and special new greetings from our new CEO who just started, Mr. Walker Fromm. And I can't wait to have Walker join us next month on SADS Live for a meet and greet and an interview with Walker. We are so excited at the SADS Foundation to see what seldom happens well in nonprofit organizations, but has happened for us at SADS very well. And that is a very smooth, successful, exciting handoff where the torch has been passed, the baton has been handed off from Alice, who's led us beautifully these last 20 plus years, and now taking us into the third chapter, Walker being the third CEO of the SADS Foundation. And so I'm really excited to have Walker join us and be with you all. But today is question and answer day. A couple announcements before I look for your questions and give you my answers. See some of the hats in the back? I always have to think of one of our favorites and one of the great SADS volunteers and her grandson, Owen, thinking of you and praying for little Owen. And then one of my favorite new hats that some of you might have seen in the background. Look at that. So this is from one of my patients, a great young man, Nolan, who is homecoming king at his high school and gave me his crown. Now I'm waiting for his home run. So Nolan, get out there and hit that second home run. The first one went to his dad and is in his dad's man cave. So I'm looking for that second one, Nolan, if you're out there. Well, we are in the midst of No Ball at All. It's been a fundraising activity where there is no ball, but we're more than welcome to have you join us in donating for the spring fundraiser. It's a very important part. We need your support. We need you to connect us to those who have means. If it's not you and you're one note away from somebody who does, link them to the SADS Foundation. Share with them the vision and mission of the nonprofit advocacy organization devoted to families with SADS conditions like yours, whether it's long QT syndrome, you're part of our family, CPVT, Brugada syndrome, ARVC, ACM, whatever is your entity where we are your home, join us and join us in No Ball at All. Next week, we are kicking off, well, not quite next week, but in about 8 days, kicking off the CPR, cardiopulmonary resuscitation, and AED, automatic external defibrillator awareness week. That's June 1 to June 7. And so my pitch for that is it starts in June, it ends on my birthday. And I would love a birthday present, and that present could be you donating to SADS or joining the SADS Foundation email list. You'd be part of our email list. So our team sends out incredible information and updates. Join the email list if you're not part of that. So CPR and AED Awareness Week starting next week, or starting June 1st, ending on my birthday. And then we'll be back with you in, I guess it's going to be 3 weeks, or 3 weeks. For June 13th will be our next SADS. And now with that, the first question has come on in. As you know, I don't cheat. I take them in order. I don't skip them. I ask that you try to keep them tight so I can read them quickly. And I do not give personal advice to you because that won't be fair. It's not accurate because I usually spend 60 to 90 minutes with a new patient. What I do try to do, and what we do here at SADS Live, is take your question and try to give comments surrounding that scenario, what things we think about, what things need to be thought about, and what lessons are there to be learned from your Outstanding questions. Well, here we go. 35 minutes on the counter, and from Dawn, and that's a new last name, so maybe new to SADS, whether it's through Instagram or whatever social media platform, Facebook. Great to have you and nice to meet you, Dawn. How is it possible for a family to have two children with a gene mutation of ARVC? Also, one of those children have a child with DSP gene, and the other has a child with PKP2, and two others with HCM. Wow, that's a lot. That's interesting. And what we're going to use that question for is to make sure that things match, that things make sense and things fit. Now, can a family have more than one kind of genetic heart disease or more than one kind of genetic subtype of ARVC, arrhythmogenic right ventricular cardiomyopathy? The answer is yes. Most families have the family mutation that is the cause for long QT syndrome type 1, or the cause for ARVC, PKP2 ARVC, or the cause for Brugada syndrome, SCN5A Brugada syndrome, meaning it's the cause. And that cause can be traced through the family. Who has it, who doesn't have it? Guilty, innocent, guilty, innocent. And those who own the mutation, we need to evaluate carefully. And those who don't own the mutation can potentially get dismissed. Now, what happens when we're getting reports within a family structure that this family has DSP, that's one of the ACM genes, builds a protein called desmoplakin, whereas another family member has PKP2, a gene that builds the protein plakophilin, which is the most common genetic subtype of ARVC. Doesn't quite make sense. Is it possible? Is there a mistake? And there we have to look at the genetic test results very carefully to see if it's tracking correctly. Is it labeled correctly? Is one variant the cause and the other is a bystander, sometimes called a variant of uncertain significance? And sometimes those variants of uncertain significance are variants of definite significance. They just have been labeled wrong, or the company isn't quite ready to promote the variant designation to likely pathogenic. Other times, variants of uncertain significance are immediately demoted to doubtful significance and are relabeled as likely benign. So we have to be very careful in our analysis of that. I hope that gives you some ideas. And then Sarah Wise says she has a VUS, that's that variant of uncertain significance in the SCN5A gene, has tested negative with the procainamide challenge. She's had runs of NSVT, non-sustained ventricular tachycardia. We're treating with beta blockers. What are the chances I could still have Brugada? Really good question. And importantly, a negative procainamide challenge is good, but it's not absolute as a rule out for Brugada syndrome. But it's a good start. So with a negative procainamide challenge and a normal ECG, then I start staring at that genetic test report really carefully and say, well, what do I think about that genetic marker? Do I agree with its designation as a VUS? And sometimes we're stuck and it stays a VUS, ambiguous, uncertain, don't know yet. And sometimes we can look at that and say, well, wait a second. Why did they call it that? It's not that. It is a definite disease mutation, or it's definitely not. So if I have a clean clinical evaluation, then I start doing my detective work on that genetic marker. Alexandra's has a 6-year-old son. He's asymptomatic, but his ECG is spontaneously showing the Brugada pattern, and they have a Brugada gene mutation in the only definite Brugada gene, SCN5A. There's no history of sudden cardiac arrest. They're not treating your son now. What's the risk of sudden cardiac arrest? Can we predict that? Can Brugada syndrome be successfully treated with ablation? Great sets of questions. And so again, not specific about your son. I'll tell you the approach to my patients who are children who've never had a symptom, but they show the Brugada pattern spontaneously. Do they need to be treated? Not necessarily. Do they need a defibrillator implanted? No, mostly no. I then start to look at, yes, they show the pattern, but are they showing any other electrical features to suggest presence of more risk? And that's something that's been called QRS fragmentation, meaning when you look at the trace, look at the QRS and the intervals, does that QRS look nice and smooth, or does it look fragmented, jagged up, jagged down? The more fragments there are in the QRS, that's the suggestion that the substrate may be more irritable. So if they show the pattern, but the QRS is super smooth, there are no symptoms, I will watch and I will outline the Brugada preventative measures. Now, I don't think cocaine's going to matter for your 6-year-old, so I may not mention that one. But the other things of prescription drugs to avoid, fever to reduce promptly, and things like that. Now, can it be ablated? Yes. There's quite a literature emerging about the experience with so-called epicardial ablation in the right ventricular outflow tract, and it can be very effective. Do we do it in those who have never had a symptom? Almost never in our program. Where we do the ablation in those who Brugada is irritable, it shows itself, it's needed to be treated. It might have started with cardiac arrest. The person now owns a defibrillator and the defibrillator is getting called into action. Might we then think about medications, quinidine, or a procedure, ablation, to try to make the next Brugada episode as unlikely as possible? Almost never need or have done ablation in the pre-pubertal age range for Brugada. Can we take I'm not sure what supplement that is, L-thiamine. Maybe we'll see if that spelling gets clarified for Kim, and I'll look for that. I'm not exactly sure of that supplement. I don't recognize that spelling. But in general, I'm not afraid of almost any supplement for Brugada syndrome. I'm trying to think of any supplements that have jumped to the top as being Brugada agitating. And really, very few come to mind. There's a few in long QT syndrome as potential supplements that could be QT irritating, but even there, not very many. Do I see from Ashley any role for AI, artificial intelligence, in helping eliminate that gray zone of is it Brugada or not? Yes, I do. In fact, we at Mayo Clinic are working on an artificial intelligence ECG algorithm to refine or do better at the root diagnosis of distinguishing the true Brugada pattern from noise or really false positives. So stay tuned. We and others are working on that. And I think we will have AI solutions that will be superior to the ECG readers in sleuthing and staring at the electrical traces. We already have an AI ECG solution that we published from my program for long QT syndrome, where we can look at an ECG where the QTC is at or above 400 and with pretty high confidence tell you if it's at or above that number because there's a mutation there, meaning a long QT syndrome mutation detector from staring at the electrical signals. That has not made its way to a commercial diagnostic assay yet, but it is becoming part of our AI ECG solutions that are on what are called our Mayo Clinic dashboard. So a lot of progress happening in the AI assisted diagnostic space. Brooke is asking, what do I recommend to be put on a medic alert bracelet? Looking at purchasing for a husband and daughter, not sure what wording is most effective. I like that question, Brooke. A couple thoughts about the bracelet. Should we not wear one? I kind of view it as optional. And the reason I say that is I've never mandated it. And about half my patients have chosen to get a bracelet or a necklace. About half have chosen not to. And so far, it has not mattered which half you belong to as to whether those who didn't have it, we wished you would have, or those that did happen, did something go wrong. So I think if you feel empowered by that alert, by that bracelet, not a bad idea. If it bothers you emotionally and making you feel that this isn't helpful, then I actually don't feel compelled to recommend one. Now, what should it say? For me, I make it very simple for the bracelets. First line is my diagnosis, long QT syndrome, Brugada syndrome, CPVT, ARVC. And then the next line is the more important line, 2 words, shock me. Because that way, if you are found down, compromised, and first responders get to you and look at the bracelet, even if they don't know what ARVC stands for, they do know what shock me stands for. And that will activate them to the resuscitation drill of the most important component of the resuscitation for somebody with a SADS condition, and that is rapid access, application, and delivery of the external shot. Beth is just catching up now, and did I miss a question from last time? And then Genevieve follows with the question. So here is Beth's question. So you haven't missed anything. Perfect timing. Do I know if there's any link between the RYR2 gene and the SCN10A gene? Your husband's younger brother passed away suddenly, age 7, 20 years ago. And after our son had chest pain after soccer training, he was tested, and both children have the RYR2 gene. Do you also know if there's an RYR2 gene in high levels of lipoprotein A? Now, remember, true disease mutations, that's a great question, Beth. True disease mutations in RYR2 cause one of 2 type of RYR2opathies. The most common is the entity called type 1 catecholaminergic polymorphic ventricular tachycardia, or CPVT1. The other, which is a newer entity, is when that mutation damages the protein in a loss of function way, and we call that entity calcium release channel deficiency syndrome. We don't mention that one very often. It's much less common than CPVT. Now, is there a link between RYR2 and SCN10A? I don't think so. Not to my knowledge, for sure. There is a potential link and interaction between the product of SCN10A, which happens to be called the NAV 1.8 sodium channel. That's a little confusing. And the LQT3 Brugada gene, SCN5A, which builds the protein called NAV 1.5. And it looks like those 2 products, the 1.5 subunit and the 1.8 subunit, can potentially interact in some way, either at the protein to protein level or at what's called the mRNA or transcript level. Now, does RYR2 interact with that? I don't think so. It wouldn't make sense for that. As to an interaction or a connection between ryanodine receptor, RYR2, and lipoprotein A, no, I don't buy that one. I've never seen it. It is possible for RYR2, which probably affects about 1 in 5,000 people, have RYR2 disease, genetic heart disease, either CPVT1 or the opposite side, calcium release channel deficiency syndrome, and separately have a hyperlipidemia of a variety of types, whether that's hyperlipoprotein A disease, for which there can be a genetic basis. And so family members, if there's elevated levels of lipoprotein A formal risk assessment needs to be done for the possibility of atherosclerotic heart disease or coronary artery disease. Nicholas is asking a non-SADS question. Well, we'll take every question because I can't skip. But is there a certain PAC burden, and these are premature atrial contractions, that you would consider ablating? Or is it more quality of life and symptomatic relief? Had one scheduled, but then canceled after my EP spoke to colleagues. History of successful AV NRT ablation 13 years ago. Atrial bigeminy with intermittent new onset. So they're definitely non-SADS, definitely not genetic, and as such, it would be really important to have it carefully reviewed as you've had it reviewed with that heart rhythm specialist to weigh, do they think that the source of those PACs comes from a spot and can be successfully targeted and mapped and eliminated, or whether there's other strategies to reduce the symptoms from that, whether it's medications and so forth. But you would be in good hands with a non-genetic, ordinary adult heart rhythm specialist. And Genevieve updated Beth. Beth gave the thank you. Superior to, I'm not sure what that's in follow-up, so I'm just going to press on. Genevieve is sharing from Charlotte from Instagram that she is PKP2 positive. Remember, that's the most common genetic subtype for ARVC. And overall, about if the diagnosis of ARVC is correct, about half, maybe 2/3, will have a positive genetic test result. Of that half or 2/3, about half of those own the PKP2 version of ARVC. And so here has a family history, and I have a diagnosis of HCM, hypertrophic cardiomyopathy. Any knowledge of people having both? Good question. Very good question. In fact, a colleague, a dear friend of mine, just asked me the question last week whether I think PKP2 can cause a different cardiomyopathy, not called ARVC, but called HCM. Now remember, HCM stands for hypertrophic cardiomyopathy. And honestly, I have not seen that, meaning where I thought that PKP2 can cause maladaptive thickening of the heart muscle, maladaptive cardiac hypertrophy, or HCM. So call me skeptic on that one, skeptical or askeptic on that one. I would be wondering if a person truly has hypertrophic cardiomyopathy, then when we had done the genetic testing, did we look at the HCM genes, or maybe we ordered the ARVC only panel of testing? Now, can some individuals have both cardiomyopathies, HCM and ARVC, independently, one due to PKP2, the hypertrophy due to something else? Possibly, but that's really, really rare. And then a follow-up from Nicholas saying, very easy to teach long QT syndrome with a cardia to use Bizet. It can be off if the patient is, so yes, just details about if a person is choosing to try to do home monitoring, the one device that is mentioned there, the Cardia's AliveCore device called Cardia Mobile. Full disclosure, Mayo Clinic has invented from my lab IP that lives in that device for its QT diagnostics. And that QT diagnostics or QT analysis got FDA cleared several years ago now, but got cleared under a prescription requirement, as opposed to the atrial fibrillation detector that's in the Cardia device, which has FDA clearance as a consumable, non-prescription turn on. So we're stuck, honestly. We're trying to get it unstuck because we feel that they should be able to just turn on the QTC diagnostic feature as a consumable observation and not require a prescription from a physician to have the company turn on that feature. But that feature is extremely accurate. We vetted it and revalidated it. And it's just hopefully a matter of time before we can get it FDA cleared as a consumer driven product, if you will. And Beth, you are very welcome. Rona from YouTube. Can I explain the latest research on playing sports with prolonged QT? Mother of a 9-year-old son who has a long QT. Well, it's not new research. It's actually very old. We've been researching this now for 25 years in our program when I swam upstream and defied the rules at that time, which basically in 2000, when I joined Mayo Clinic's faculty, was the law of the land and the world was, if you have long QT, if you have Brugada, if you have ARVC, if you have HCM, doesn't matter. If you have a heart condition, you are disqualified from all competitive sports. That never made sense to me back then. It definitely doesn't make sense to me now. So we started empowering a dialogue with families to see, would it be reasonable? Could we safely return an athlete who just loved his or her sport and needed to continue it to do that despite having long QT syndrome, despite having HCM? And after doing this now for a long, long time, and following 800 athletes that I've returned to their sport, the answer is yes, we can do this. And the guidelines have now shifted from you're kicked out to an empowerment approach of shared decision making, whereby it may be reasonable to let Johnny, Sally continue in their sport. And so sport, is it potentially dangerous in long QT syndrome? Yes, of course. That danger is almost exclusively those who are undiagnosed and therefore untreated. And that's how the disease showed itself. But after correct diagnosis, initiation of correct therapy, and proper monitoring, that threat of that sport being irritable is neutralized a lot. Now, do we declare them cured? Of course not. Is the risk zero? Of course not. And so we have precautionary measures in place. We have an emergency action plan that's universal. But my view is I am not afraid of sports in any of my patients with diagnosed and treated long QT syndrome. None. And if that sport is what that makes that child, that adolescent, that young adult, that middle adult thrive, then we figure out how to keep it part of their life. And so great question. We could talk a lot about that because our program really provided the pivot point for us to go from a guilty as charged and you're locked up for life to being free to continue to do what you love to do with proper precautions. It's a great success story, I think. Hannah is sharing that her daughter and Hannah have the SCN5A gene, and they call the symptoms Brugada-like, but the ECG doesn't show it. You're both symptomatic with episodes of VT, SVT, and AFib. Does that mean we could still have Brugada syndrome? Also, is there any gene therapy for SCN5A? Have 7 family members. Now, super question, super good one. It's uncommon when I have patients where their SCN5A mutation definitely is categorized correctly as likely pathogenic. We already know, let's say from functional studies, that it causes the Brugada-like loss of function damage to the protein. but then they have arrhythmias and yet their ECG is normal. That's unusual. Most patients who have identifiable arrhythmias from their disease mutation will show at rest the ECG features of that disease. So that would force me to do a timeout in my program and ask, is the patient's symptoms because of this genetic marker? Is this genetic marker really invisible on the 12 lead ECG? Or did I make a mistake somewhere in my detective work? As to gene therapy for SCN5A, we've talked a lot about gene therapy on SADS Live. It's an exciting phase we're in. Gene therapy trials are in motion in patients with PKP2 mediated disease. They're in motion with patients with MYBPC3 HCM. There's going to be a gene therapy trial starting in humans with CPVT end of this year, more likely early next year. For long QT syndrome, not yet. We're advancing that from my research team. A key trial is in motion in the rabbits as we speak. Hopefully we'll have the results by this time next year. So LQT2 gene therapy in humans is at minimum 18 months to 2 years away. And that's assuming the rabbit trial is successful. SCN5A, there's an issue there. That gene, SCN5A, does not fit in the AAV delivery cargo. So it's too big. We think we have solved the too big issue. And so we're working in the dish to see, does that work? And could we have an AAV, a gene therapy strategy for what traditionally has been a gene that's too big to fit into our top therapeutic cargo delivery system, which is AAV9 or AAV8, that type of adeno-associated virus or AAV. So not yet. SCN5A is well behind LQT2 in terms of our research developmental pipeline, but we've made some success. And so we'll see on that. Amy, as we're coming towards the close of this almost second to last Friday of May, before we all head off for Memorial Day weekend, and I hope you all have a wonderful weekend. But Amy, let's see if I can fit this one in and go and see what we have left. It's a little long. Have I come across many patients with CACNA1C gene mutation? Amy and her youngest daughter were both diagnosed with a gene, which is LQT8 or Timothy syndrome. She's been asymptomatic. She's 10, and you've been symptomatic with a faint, and now you live with an ICD. So yes, we know a lot about CACNA1C. Now that gene builds a calcium channel. We haven't said that type of channel yet on today's program. And we know that LQT8, which is the calcium channel version of long QT syndrome in our program, is probably the fourth most common genetic subtype, or tied for fourth. LQT1, number one, 35 to 40% of all my patients. LQT2, number two, about a third of all my patients. LQT3, the sodium channel version, about 5 to 10% of all my long QT families, 5 to 10%. And then LQT5 is about 1 to 2%, and LQT8, which is the calcium channel version, about 1 to 2%. So I have about 2,000 patients with long QT syndrome. That means I have about 20 or so with LQT8. Now it gets a little confusing because depending on how that mutation in that calcium channel gene damages the calcium channel determines on as to whether I show the original syndrome called Timothy syndrome. And there were 1 or 2 specific mutations that damaged the protein in a certain way that it caused extra issues besides just damaging the calcium channel. And those extra issues is part of the reason for the non-cardiac other symptoms of Timothy syndrome, which can be the syndactyly of the fingers and of the toes, and immune system issues, endocrine sugar balance issues, and so forth. So there are a couple mutations that are true Timothy syndrome mutations named after one of my dear friends, Catherine Timothy, who was the nurse who really found and studied and organized these Timothy syndrome children. And then there is LQT8, and LQT8 is actually more common than Timothy syndrome. Timothy syndrome affects maybe 1 in a million, 1 in 2 million children. LQT8, let's say long QT syndrome is 1 in 2,000 people. And if LQT8 is a 1%er, that's 1 in 2,000, 20,000, 1 in 200,000. So it's about 5 to 10 times more common than Timothy syndrome. And our management is driven by how is it showing itself electrically? Is the QT super long or normal? Has it behaved or misbehaved? Are there any other features of the disease? And so importantly, just because one person got an ICD, that doesn't mean that the other people who own the same genetic marker will ever need an ICD. Maybe yes, maybe no, but it doesn't matter that somebody's already gotten one. Let's see, 3 minutes to go. Will I be able to do justice to Wendy's question? I don't think so. So if I could, I'm going to ask Aaron and Genevieve and Anna to mark these so that on our next Q&A time, we start with Wendy Marie's question and then Kayla Bruce's question next. So this brings us to the end of SADS Live 165. Remember, no ball at all. Join us with that. If you've never donated to No Ball at All, would you do so this time? Remember, by the time we're together again, we'll have already finished the first week of June, and for which we are celebrating and recognizing and emphasizing CPR and AED National Awareness Week. So do your part for that. Join us during that week. Go to the SADS Foundation and connect with us and get on the email list, and do that as my birthday present, which is June 7th. And then for our next time, it's either going to be, I will be with you on June 13th. I hope you join me for SADS Live 166. And either that time or 2 weeks from then, I am really looking forward to a dialogue and an interview with the SADS Foundation's newest CEO, Walker Fromm, and to get our comments and his thoughts on his vision for this next chapter in the history of the SADS Foundation. So until next time, be well. I did say we're coming upon Memorial Day weekend almost as soon as we hang up together. So I hope you have a wonderful weekend. Like you, I too will be remembering as we honor what Memorial Day weekend is all about, and so grateful for the men and women in uniform in the United States, past and present, for protecting us and giving us the freedom that we all cherish. And I thank those families who will not be together for Memorial Day weekend because their loved one is deployed elsewhere or perhaps has already paid the highest sacrifice of giving his or her life for this amazing country of ours, the USA. So have a wonderful Memorial Day weekend, and I look forward to being with you in June.